Good morning, good morning, good morning. Kevin, I think this is the first time you've been on. I think that you can actually unmute. I'm not quite sure how to use it with this particular program, and I don't have a subscription to Zoom, but I think you can unmute to ask questions and things like that, um, or use the chat function. Try to keep my eye on that. I'm going to wait another minute or so. I've got some more people scheduled. Some people scheduled so they have access to the recording, which you'll get an email later with the recording as well if it's interesting for you. Okay, I'm Dr. Gordon Elder. I'm a upper cervical chiropractor of the Blair flavor. I've been doing the Blair technique since I graduated chiropractic college in 1999. Started learning the Blair technique before I even went to chiropractic college, as my chiropractor was Dr. Blair's co-conspirator, co-developer of the technique, perhaps. Certainly one of his best friend and somebody who field tested some things for him once Dr. Blair uh, wasn't practicing anymore before he passed in the mid 80s. So what we're going to do today. So first of all, I'm using Horos, Horos, because I use a Mac and it's the free program. It's actually a good program. It started out as open source. Um, and it still is, but it was bought by a company. So it kind of has the advantages of both. So if you're using a Mac, this is a great program. The free program that is probably the best quality for a PC is Carestream 3D. It is made by Carestream company. However, they do deliver it for free. There are some things on there you can't do unless you have a registered, or they don't want you measuring the airways unless you're a dentist. Which on Horos, I'm not sure that I can measure airways specifically, so the volume. So there's some things that are pluses and minuses, but for our purposes, for a Blair analysis, this is a great program. So this this webinar is not a training manual on Horos. We're just going through the basics of the Blair analysis as taught by the Blair Society currently. It is also not a pathology seminar. So I would expect you to scroll back and forth and look for pathologies, write those down, do your due diligence, write your report, send it off to a radiologist, a DAC perhaps. I do both. I send mine off to a radiologist, a DAC as well as doing my own report. My own report, because I send it off to a radiologist, my own report, I don't spend too much time detailing the location of every little spur, but I do note uh, everything down that I see. So this is not that. This is just a Blair analysis seminar. And so we have here on Horos. Now, the first thing I've done is make sure that right is on the right and left is on the left. And the reason for that is because Horos will automatically come up and I can't change the default with left on the right, on the reading right, and right on the reading left. So I've already changed that in the program. The Carestream 3D, you can actually change the default, which is a nice feature for that. I've already gone through and looked for pathology, so we're just going to delve right into the analysis. And what we're going to do first is set our reference points. Now, the Blair system uses the ground currently, and I think we'll change that, but currently we're using the ground to measure against, but we're also using the ear canals. So we use the ear canals to take out rotation and take out head tilt. Why the air canals? Because we've used it before for that, and so it was just a natural extension, and it doesn't seem to be a good reason to change for our technique. We can see the air canals as we're walking up to the patient, so we have an external reference for internal structures. So what I'm going to do is I'm going to find the ear canals on the little screen here. And here, oh, let's see. First thing I'm going to do, it starts off at my machine does 0.3 millimeter slices. The radiologist will tell you that 3 millimeters is kind of the minimum slice you should use for analysis, generally speaking. And we're going to actually fluctuate back and forth between about 20 millimeters and 3 millimeters. Also, we're going to change this to mean. It just gives us the more CT scan or X-ray like view, which is going to, for our purposes, be the most useful. All right, so I'm going to drag the crosshairs roughly to the center, and I'm going to go through the ear canals. Now I like to look here where the mastoid is and kind of balance it with that, because that's getting pretty close to the foramen magnum. And we look here on the right side, and we're going to tilt it. So now that any measurements I take are going to be related to the skull. Now, personally, I also change this line. I like to have it level with the hard palate, and then reference the line between the top of the ear and the corner of the eye, which roughly they're parallel. I have found out through checking pretty much every patient that they're mostly not. They're roughly parallel, yes, but some people have a greater degree. So we actually use a correction factor for that when we're adjusting here in the office, but that's not Blair technique. We're not going through that right now. We're just going to say, okay, we're coming in level to the ground and rotated and tilted according to the external auditory meatuses. Now, in this particular program, when I move away from here, it would be nice to be able to set this and just be able to, whenever I press the reset button, just go back to this position. But this program won't do that. So I had to figure out a way to set this as much as possible. And most of the measurements and markings you can make on this will disappear as soon as you leave that particular plane of reference, and they don't come back. Now in Carestream 3D, they kind of stay permanently on that plane, so you can move away, they'll disappear, but as you go back to that plane, they'll show up again. That's got its pluses and minuses. This particular, it's called an ROI, this particular ROI, the points, these actually will stay in three-dimensional space. And so we're just going to go ahead and line them up so that I can come back to this position if I move away from it in order to make my measurements. Okay, there we are. So first thing we're going to do is analyze the base posterior. When we did this with x-rays, we came in at about a 45 to 50 degree angle. The typical practice now, we still need to do studies and see how it changes things, if any, but it seems to work the best. So right now what we do is we kind of go with the Atlas plane line. The way that we look at the Atlas plane line, and we're actually going to measure it in a moment, but in fact, I should have measured it before we moved away from that point, but we'll come back to it, is going to be the center of the posterior aspect of the anterior tubercle and the center of the posterior arch. So right now we're just going to eyeball it. We don't need that to be real specific for this time. And that's going to give us a fairly nice en face view of the Atlas. Now we're really at too small of a slice depth. So we're going to move this to, I'm going to go ahead and just put in 15 for now. What that does is that if you look at the far right, is that gives me the whole facet on each side, the condyles, the whole joint, top to bottom, and the belly of it. Now I could go to 20 and get the whole thing, but pretty much the whole lateral mass on each side. And you can say I moved this up just a hair. We're still parallel to the atlas plane line, but now we're at the AO joint. So now I can see my atlas really close. Now, side note, we also are going to be looking at the styloid process in relationship to the transverse processes in our clinic. That gives us some idea about the structures in between, and if they may be, without having an MRI, if they may be impinged on a little bit. We're going to darken this up just a hair. Okay, now the first thing we're going to do is we have to come up with a calculated convergence angle of those condyles. So those condyles are pointing inward, and we need to be able to measure that so that we can see the proper margin of the AO joint where it should line up if everything is if everything is lined up properly. If there's no misalignment, there's a particular point that is the most consistent on the AO joint that that we need to be able to find. And first we need to find the convergence angle. Now in the Blair technique itself, we also use the convergence angle for some of our adjustments, although it's always a secondary measurement, not a primary. So we can kind of see the lateral mass here. And so what Dr. Blair did, since on a plain film x-ray, you could not consistently or well see landmarks of the condyle itself, but he could consistently and well, every patient, both sides, see particular parts of the atlas. He used the atlas primarily for his analysis. Has an algorithm to figure out the convergence angle that will get us the information we need. So we're not actually measuring the actual convergence angle of the condyles, even though we call it the condylar convergence. So we find this dip anterior. This is anterior point 1. We find this dip here, and we look. Now, Dr. Blair would use where the foramen magnum came in and crossed over the lateral mass. Most people nowadays just use where the posterior arch comes in and attaches to the lateral mass. You can see that if I do that, it's going to be a slightly different place. On this one as well, slightly different. So we're going to do what Dr. Blair did and use the, let's see, am I seeing? Yes. We're going to use that, and we're going to come over here. So we've got a line. We've got anterior point 1, posterior point 1, line 1, 1, if you really need to name it. And we're going to come out 90 degrees. Now I got pretty close. We're just going to come to the edge of the lateral mass there. Now we're going to do the same thing. So if we were doing this on a plain film, we'd just be drawing one line and then going parallel to it or perpendicular to it out to the lateral margin. Now again, we're not looking at the joint here. We're looking at the lateral mass because he couldn't consistently see the joints on a plain film. And it takes more work, and we found that this actually works. Okay, so I've got those lines. This is going to be anterior point 2. This is going to be posterior point 2. We're going to bisect this line and draw a line straight through there, and that is our convergence line. So most of us tend to eyeball it, but for the sake of instruction, we're actually going to measure it. Okay, we got a 9.1, so half of that is about a 4.5. Now I'm going to leave this line a little bit at an angle because as soon as I walk away from it, if it's right on top of that line, it'll disappear and it's hard to find again. So we're going to come in here, boom. I didn't get that other one quite right, so we're going to grab that. Okay, so we've got about 1, so about a 5. Okay, so those are our 2 points which we're going to make a line. I'm going to go ahead and put those dots that don't move so that things don't disappear. There's a particularity of this particular program. Okay, now we're going to measure the angle in a moment when I go back to center and get all my lines properly, but let's go ahead and get those 2 dots that we're going to make the line for on the left side. You can see how the foramen magnum is coming in about right there on this gentleman. Good. 90 degrees all the way out. Now, with cone beam, as we figure out some better, this is going to evolve. There we go. Come on. As time goes on, to have maybe some better ways to do this, because we can see more, we can isolate things a little bit more. But right now, that's what's going on here. Now, just to save time for this particular, I'm not going to go ahead and measure. You can see that's the proper way to do it, but let's just, yeah, looks pretty center. Looks pretty center. Okay. Now, we're not going to measure that yet, but this is going to disappear. So you can see as I move away, the lines disappear and they don't come back. All right. So we are going to recenter ourselves. And then when I measure things, we are still, now the rotation and the tilt, I didn't change, so I'm not worrying about those too much. I'm just trying to get everything centered. Now let's go back down. Okay, there's our dots. Now, we'll go down so it's a nice pretty picture, at least as pretty as we can coming in at this angle. So now I'm going to measure this. We're going to bring our crosshairs back. If you use this program, if you hit the space bar, you can get rid of the crosshairs. And that's useful because if you get too close to the center one, suddenly you're going to start rotating. So it's nice to get rid of it if you're crossing over. I'm going to back up just a bit. So I have plenty of room. We're going to come in, angle. We're going to start here. Just going to use this parallel one over here. And we have our left convergence angle, 22.8. So basically 23 degrees. I like putting the tenths in there so I know how close, but practically when it comes to using it for adjustments, there's no way that we're getting our ulnas exactly along those angles. Fortunately, it's not necessary with the Blair technique because we use a variable line of drive. Okay, so I've got my two convergence angles. I'll go ahead and take a picture of it for my records, write it down. And now what we need to do is we need to get the measurements of the slope of the joint and the convexity of the joint before we even analyze. Well, the reason I do it before I analyze is because once I start analyzing, I'm going to be moving those crosshairs all around, and then I have to go back and reset everything when I want to measure. So we're just going to measure. Let's go parallel to the right one. We can see here the slope on the right, in the right panel. Can't really see the convexity very well. We're going to take the posterior. Now, when we did this with plain film, we would look at both sides. So for example, here is a convexity of the left side. The problem is it's not a pure convexity. It's good enough for our adjusting and those kinds of things. But if we want to be just a little bit more precise, we're actually going to look perpendicular to the convergence angle to get the pure convexity back here as opposed to coming in at this angle on the opposite side. So we're looking at the right convexity and the right slope, and that's what we're going to measure. I think most Blair doctors are doing that at this point. I can't see that real. Oh, actually, I can make it out pretty. I can make it out okay. We're going to come up here. We got that. Boom. Okay, and then we're going to line that up with the line that we said was level with the head because of the head tilt. Okay, so there's the right slope, 28.8. And the convexity, you see it right through here. Now we always measure the bone that we are going to be adjusting to. So if the atlas is misaligned, we're going to use measurements other than that convergence angle. We're going to use the measurements of the condyle because we're adjusting it back to the condyles. All right, and now we had that. This was pretty straight to the floor. Like I said, I don't use this in particular one in practice. I'm playing around with some other things that I think will get us some better holding times, more precise adjustments. But there we have it. There is the take measurement, the right slope, and the right convexity, both kind of within average ranges. Let's measure the other side. We're just going to do exactly the same time. Then we're going to actually analyze the joints to see what direction the bone has moved. All right, so but we don't need, if you're just using the x-rays for analysis and not for coming up with your adjustment vectors, you don't really need to measure this. Now, it will help you understand the biomechanics because obviously the angle at which the joint slopes or converges, or the fact that the biomechanics of that particular joint in conjunction with what's going on the other side. So it does bring us some very good information just from a biomechanics standpoint, because you might decide, if you have an option, of how you're going to adjust that. In Blair, we have different options. You can adjust on the left or the right. Dr. Blair determined that the atlas doesn't move a whole lot, but when it does, the primary motion is anterior or posterior. The laterality is not the primary, so you can actually push it back from either side. You're just going to use different leverage points. And you can see that as the convergence angle, if the convergence angle is 45 degrees and it had moved forward, it would move forward equally to the front and to the right. But most of the time, the convergence angle is 18 to 33 degrees. So if it moves forward, the primary direction of misalignment is going to be anterior with a little bit of, in this case, right. We're looking at the left side. It's angled towards the right. So if it goes forward, it's going forward to the right. If it goes backwards, it's going backwards to the left. All right. So we have the left side. I can't remember if I took a picture of that, so I'm going to go ahead and do it for later reference. And we have, now we're going to analyze the joints to see if they're misaligned or not. So the easiest way to do that, now we could change the thickness, and I will in a moment. But remember, Dr. Blair was looking at these things full thickness, right? Because he was on using plain film. So if we're going to do that and still cut out all the overlying structures, we might do a 20 millimeter. But we're not going to do, we're going to do 15. That's pretty close. So we're looking at the joint. Now he came in through the maxillary sinus. Actually, he initially started looking at the sagittal AP plane line of the atlas and coming into that. But a lot of times the orbit would get in the way. So then he was moving up and kind of coming down through the orbit, through the bottom of the above the bottom of the inferior portion of the orbit here. But then they realized that if they went through the maxillary sinus, they got really good results. So let's just angle it up a bit as though we're going through the maxillary sinus. So we're angling. This guy obviously has some mucosal thickening in his right maxillary sinus, but you can see we're coming in through the sinus. So this would be very much, and it looks like because of where we put our dots, it's actually along the atlas plane line as well. So we've moved that up, and we get a little bit clearer shot through here. I'm going to go ahead and remove those. Now, it's not super clear. It looks like maybe, keep going the wrong way. Here we go. Maybe it's the lateral margin of the lateral mass is more medial than the lateral margin of the condyle. It's not super clear. So I like to be super clear. So like I think most of us do, I start playing around with the angles, because again, we're not worried so much about what the angles are. We just want to get the right spot. And the right spot is this. We're going to look parallel to that convergence angle that we calculated. The lateral most margin. Now, really, this is, if you're just looking at somebody from A to P normal, this is going to be a lateral and anterior aspect of the joint. But if you're just looking parallel straight down the joint, it's going to be that lateral most margin right out here. So this is the most important part. This part, most consistently, if the atlas is lined up with the skull, according to Dr. Blair's research, both with X-ray dry specimens and X-raying dry specimens, this part should line up. So we should see this and this line up, and it's pretty close. But let's play around with it. Let's go back down to the 3 millimeters. So I typically will do 3, 5, 10, 15, sometimes 20 millimeters just to see what I can see. Now, what I'm going to do here is I'm going to change this to go right along the joint. I'm going to look over here. This is right along the joint tangent to that curve. And this is in the right place where we're actually looking. If we have that parallel line, we're out here looking at that joint. All right. Good. This one would be probably too close to call. I would probably put down an underlap with a question mark, but it looks pretty even. And if we remember what Dr. Blair was looking at on plain film x-ray, then he wouldn't be able to see that small of a difference most likely, except on very, very clear shots, very, very clear specimens. So let's do just for the, now that we got something pretty clear, let's go ahead and do the whole joint. And we're going to bring this down to here. We're going to rock it a little bit. Yep. I think what I would do in this one is I would do some neurological testing of the patient, some leg tests and things like that to see if I thought clinically, but I'm going to call that even. So even with a question mark, possible underlap, which means if it's an underlap on the left side, that means the whole joint has been pulled backwards and to the right. And so it's a little bit, atlas is a little bit more medial to the condyle. All right, I'm going to take that. We're going to take a picture. Boom. Got that one analyzed. Let's move over to the other one. Now we're all kind of cattywampus, so I'm going to straighten it out just a bit. It doesn't have to be perfect, but enough so where I can see my reference points. We're going to come over here. We're going to line up with the convergence angle. Now this, I'm just going to go ahead and start by lining it up with the actual joints. We're coming through the maxillary sinus. Okay, with the thick one, hard to see. Now you can kind of follow the anterior margin of the joint around here. So let's go down to good, and right through the joint. Now this one is obviously, well, let's get to the, now see, that's what happens. I accidentally grabbed too close to that center line and it rotates. Grab it right in the middle, then I can translate it back to the lateral most margin. If I'm just moving straight out parallel to that convergence angle, what's the tip out there that I need to be looking at? Okay, and then we're going to make sure everything's lined up. And then it's not super clear here, so I'm going to go ahead and make that line tangential to the curvature over there. I'm even going to, just in case, because the convergence angle, and again, is a kind of a calculated angle, we're going to look around. That looks pretty even. Okay, so I'm going to suspect that he actually has a very slight PIR or underlap on the right, but this could be an overlap. So every time I do this, I just pick a patient that I've analyzed in the last week. I anonymize it, and then I try to not remember what I found on them, so I'm not leading you anywhere. So we can just take real life cases. This one looks like he is even on the right. So there's a possibility that the atlas is not out of alignment. I can tell you right now, I don't think so. Now, this patient actually hasn't come in for their first adjustment yet. They're coming in tomorrow. I analyzed it last week, but I'm going to say, just based on what we're seeing today, that I probably came up with a slight underlap on the left. We'll double check. It's possible he's in alignment. but we're going to go with that. Now, so we've got the atlas analyzed. We're going to say possibly a PIR, possibly even. Maybe his major is between C2 and C3. Now, Dr. Blair did not acknowledge that there could be a subluxation between C1 and C2. Misalignment, yes. Subluxation, no. He didn't believe it could get fixed. I have found that generally to be true, even with people with very large rotatory misalignments, but not 100% of the time true. So I like to look at that as well. So I'm going to show you just briefly what I do there. I look into the neural canal for this. So usually I'll bring it back down. We'll go to the 3 millimeters. We'll change this back to the mean. 3 millimeters. I'm going to go ahead and line it up again. We're not taking measurements, so it can be just kind of basic, rough. And so what I like to look at is right back here. Now, I played with different things. It's not something that I teach as, hey, this is how we do it, because when I say we, I mean me. This is how I look at it. But I want to see if this is impinging on the neural canal moving forward or backward. I want to see the lateral mass, the posterior aspect of the lateral mass, and the posterior aspect of the superior articulating facet of C2. Now, we can, if I'm really curious, I'm saying minimal. And since most of the time this is not a subluxation area, but a misalignment area, I'm not too worried about it. That's the wrong joint. Let's go back down. But you can still apply the same principles and just line everything up with the actual joint. And we're seeing a slight anteriority, probably not big enough to cause any problems, maybe not even a problem. I'm not 100% sure yet. We can rotate. We can wiggle this. We can change the thickness of the slices to look at that. But I'll mark down that the left side is anterior. C1 lateral mass is a little bit anterior to C2 on the left. And then as we move over to the right, we can do the same thing. Usually I'm just running through this at 3 millimeters just from left to right without lining up the joints, particularly unless I'm really concerned or I'm coming back and saying, what really is going on here? This patient isn't responding the way I thought they should. Okay, anterior a little bit there. So much so that it's almost not even worth talking about. His atlas and his axis are pretty well lined up at the joints. Okay, we're going to come back here. Let's go ahead and reset. Let's go to 10 millimeters and let's look at C2 and below. All right, we can obviously see that there's a alordosis, possibly a very mild kyphosis here, down between C3 and C6, I think through 4, 5, 6. So I've got it down to C6. I'm not saying the discs look pretty good. I'm not saying any major arthrosis on the bodies, at least in that middle section. But we're just going to, let me bring that back to this because we are going to do some measurements. Okay, so here's the left joints. Now, again, we measure these to the ground. We use a variable line of drive. So we come in when I'm adjusting, if C2 has gone posterior on C3, then we're going to come in right here with our piezoform, and with a toggle torque adjustment, it opens up the joint just a little bit and slides it forward. So we need a precise estimate. I think a friend of mine, Dr. Linares, who's another Blair instructor, that's what he calls it, need a precise estimate. Occasionally, if the patient stops responding, now typically people heal up, they feel good, they don't go out of alignment that much after a while, after they stabilize. And so we're not having to keep readjusting. But if something happens, they come back in, no traumas. After the trauma, we re-X-ray, or at least we see if things seem to be the same. Excuse me. And then we redo the imaging if there's a medical legal reason to do so, or if it seems they're not responding, or their patterns have changed with thermography and the light tests, and we want to see what's going on. But if they've been a patient for 10 years or so, approximately, and then suddenly they need to be adjusted, and they need to be adjusted multiple times, then we're thinking, well, hey, the curve, by this time, I'm sure the curve has changed, which is going to change the angles of these joints. As soon as you make an adjustment, the angles of these joints are going to change relative to the floor. We don't have a good way of measuring those relative to something that we can palpate accurately. You'd think the spine is processed, but there's a lot of tissue around that. Some of them are really small. So we just use the floor, and it usually works to get them through, and then most people stay stable. So let's see, we're about halfway through. I'm plowing through this. So if you get any questions, Kevin, just let me know. So far, you're the only one there. I think everybody else is going to watch the video. But so we're going to measure these relative to the floor, which some CT scans, some CT machines don't have a flat edge down here. They have a cone shape. And so the best practice is to leave this level here and measure to this line. This is going to represent the floor. So that's what we're going to do today. We're going to get rid of it for a moment. We're going to come up here. We're going to grab our angle. Boom, boom, boom. Okay, that was pretty good. All right, we got a 35.4. Now I'm just going to copy and paste so I don't have to keep redrawing this bottom line. We've got 1, 2, 3. I'm going to put this apex back here and then, oops. There we go. Apex at the back of the joint. Now, again, we're measuring the inferior segment because we perceive from C2 down, the joint to be misaligned with the lower segment. Generally, that seems to work fine. Is that always true? Probably not. Depends on the direction of the force came in, but it seems to work either way. So for convention's sake, we're going to say we're adjusting C2 to C3. Therefore, we're going to measure C3 because that's where we want C2 to go. Now, obviously, these joints, the difference is not going to be that much different between the inferior facet of C2, superior facet of C3, but that's the convention. So we're always measuring what we're adjusting to. Sometimes they can be a little bit different. We can have some wedging in the joint. All right. Take a picture, write it down later. That's our left, angles on the left. Now, I'm not going to analyze these quite yet unless something jumps out at me. Nothing's jumping out at me. We're going to come over here. Good. And we're going to do the same thing. Now, I'm just going to paste from the others so I know that this bottom line is still level with the ground. Obviously, there's some tropism here, so we're not seeing through the joint very clear, but we're not analyzing quite yet, and I can see the line enough to make the measurement. 1, 2, 3. I have a video, it's about an hour long, of me analyzing and explaining things a little bit off Blair topic, but throw in some orthogonal concepts and things like that. It's how we do things currently in our clinic. If you're interested, I give you a link. I have it in my YouTube. I think it's uploaded to my YouTube channel. Take a picture. All right, so now we've got the angles. We're going to use those for adjustments. If you're not using these type of angles for adjustments or adjusting below C1, then that's not so useful to you. However, the analysis might be. So let's start looking at these joints. So we're here. So we're just going to go ahead and start with the right side. I'm going to line up. Well, let's do this as if we were looking at it from an X-ray. What we are analyzing here is we're trying to find the anterior margin of the superior facet and see if it lines up with the anterior margin of the inferior facet. This, Dr. Blair determined, kind of like that lateral margin or anterolateral margin parallel to the convergence angle on the AO joint. This is the most likely the one to be a mirror image. So the posterior aspect sometimes will line up, sometimes not, even if the front is, just because of the way the joints move. The anterior aspect, perhaps because that's the IVF and the body's trying to keep that as clear as possible for the passageway of the nerve artery and vein. But regardless, he found that this was the spot that most reliably on most patients, most sides, most joints is going to show us if the bone has lined up properly or not. Now, I'm going to show you some others if it's not clear, because unfortunately, the um, the okay, my words all just failed me, but basically the cortical margin of the pars. I can't remember if that's called the pars, but basically this part of the joint, this part of the bone here and the joint, they often run in together. Now in this one, we can see a little bit of a bump. So it looks like the joint ends about right here. But on many, it is very difficult to determine, so you can't see that. So then we look at a few other things. But for right now, let's just run back and forth between these. If we look here, 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 I'm not seeing anything obvious. If I go back and forth through the joint, this up here looks like there might be something going on, but since that's a turned articulation, there's going to be a better way to look at it here in a moment. Okay, let's go look at C2. Oh, the other thing is we're looking to see if they're lined up, not perpendicular to the ground, but perpendicular to the joint plane. The plane of the joint is here. So if I draw a 90-degree angle this way and a line that's basically perpendicular to the joint mark, the joint line, then we see if one has gone anterior, superior, posterior, inferior in relation. Possibly pretty close, but let's look up here so we can, let's do this. I think the easiest way. We're going to start playing with our margins. I mean, our crosshairs. Look, we can see a fairly big tropism there, which does affect how we adjust that joint, but we don't have to actually measure it because Dr. Blair didn't have a way to do so, and it seems to work fine without doing that. Doesn't need to be as precise. It's the argument anyway. Okay, let's bring this down. Let's bring this down to the 3 millimeters. Okay, and we're right in that joint, and we're just going to move back and forth. And I found that you can look at these way too close. See here and here. And so really, if you're looking at this middle one, we want to see this part here, and it's not super clear. I'm not going to worry about it too much because typically if it's big enough, usually it'll be big enough to see clearly. And so I'm thinking it's probably lined up, just the way the joint moves makes it a little bit difficult to see. But the other things that we can do is we can look at some other things to give us hints. Now, these hints do not tell us how the bone is moved, but if all of them all together say, hey, look, it looks like it's moved posterior, then we're thinking maybe it's gone posterior. So let's apply some of that. If we're looking at an anterior wedge in the joint, that would tend to indicate that C2 has moved posterior on C1. So it's like this. If it's gone posterior, it'll do that. Now, I have found, again, that's why we use these as hints. That's not always true. Sometimes you'll see a wedge when it's lined up. Sometimes you'll see that opposite wedge when it's obvious it's moved a different direction. But that's a hint. The other thing is we look at the posterior. Now, often these don't line up just because of the way the joint moves. But again, it can give you a hint. We're going to look at the very end after this, we're going to look at the central canal, do a central canal analysis, and that can tell you if something's rotated or not. But the next thing that we're going to look at here, that's easy to look at when we're in this position, is a parasagittal George's line. So we're not in the center, we're off to the side. And if the bone has moved backwards or forwards, you may see a change here. Now, because there's so much soft tissue, I mean, we've got a disc that may be degenerating or moving, plus the soft tissues inside the joint. Again, it's not going to be the gold standard, but it can give you a hint. And here we're seeing it nice and flush. So we're thinking probably is lined up. I'm not seeing anything really to convince me of anything else. Now, again, I don't go do this particular exercise with every single joint, but anything that I'm kind of questioning and is not clear, then I'll go through and do all these things. Otherwise, I'd spend 2 hours on it, every CT scan and not really get that much more information. Okay, so we're seeing a wedge, but the anterior margin looks pretty lined up right there. Back here, fairly lined up. Let's look at the parasagittal George's line. I'm going to reline up this here. Again, still pretty balanced. So I don't think he has a C2 on 3 misalignment. Again, we can go back, we can look at all of these. He's a fairly young man, although in Texas that doesn't mean he doesn't have misalignment, or with anybody, I suppose, he doesn't have misalignments, but here they've got very competitive. Let's just put it that way. If you don't know, I'm not Texan. Okay, and when I come down here, and here's another thing, we'll look at the parasagittal George's line all the way down. Just want to see where I am on that right side. If I'm looking at, yep. And see if there's any misalignments there, and then go look at those joints a little closer. I'm not seeing anything. That the center looks like, almost an anterolisthesis, but then as soon as you go out to the edges again, it isn't. So it's just the way that that body is shaped right at that point on C3. It's looking pretty good. So let's do a central canal analysis. So what I'm going to do is come down to the very bottom, line this up with the body, go straight up. Now, because he's alordotic, that's just going straight at the back. I like looking at this, the posterior aspect or the anterior aspect of the central canal, the posterior aspect of the body, and find the center and line up with the apex of the posterior aspect of the central canal. Here, let's line this up. Now, if you had a big curvature, I would probably have to keep lining this up every time. But I'm just going to go right through the center, top to bottom. And then I'm going to scroll up one link at a time. Okay. I don't see any obvious rotation, maybe a slight bit where the body has rotated to the right, but it's so small, it's like I'm making it up because I'm wrong way, amplifying everything so much. And the bodies aren't precisioned that closely. Nature doesn't do it that way typically. Looks pretty good. I mean, if you're looking here, you're seeing a rotation, but if you look here compared to what we did before, yeah, there is a little tiny bit. So the apex is a little bit off to the left. The body is a little bit off to the right. I would write that down. So on C3, 4, on C4 in relationship to C5, which is where we just came from, we have a little bit of rotation. Maybe I want to check these joints to see if it's gone forward on the left or backwards on the right. I'm going to correct that. I'll make a note and come back to it later. Now we're all flush again. We're going to compare 4 to 3. Okay, I'm going to parallel this with the back. That looks pretty good. Again, here you're kind of seeing some, it's not symmetrical left to right. The apex is not super clear, maybe a little bit off the left, but if you look at the body, still pretty straight with the one before. So that would indicate, I keep being on the wrong panel when I do that. Good. Let's this with the back. Obviously, the person has a bit of a retroflex dens, and there's a little bit of a fibroatlantodental spondylosis, mostly anterior tubercle. But again, C3 there. Now let's bring it up. Let's go ahead and look at C1 in relationship to C2. Pretty good. Okay, so we're not seeing a lot of other things. Now we're seeing that the left styloid process is closer to the transverse process on the left of C1 than on the right side. Is that normal for this person or not? We don't know, but I would probably measure that. How would I measure that? I would come over here, get right on that. We'd line up with the styloid process there, line up with the styloid process there. Look at where the closest the two come together on that left panel. Probably rotate this. We got a pretty good idea. I'll probably just do 2 measurements, see how close they are. This is not Blair technique. This is just me being a nerd. Okay, 2.4, 2.9. So we're gonna say it's gonna be somewhere in there. That's pretty close. I don't remember what normal is, but really normal is considered to be symmetrical, which is we know is not 100% true. So we'd be thinking that perhaps this transverse process has moved closer to that. Now, if you remember, when we were looking at the actual joints, it looked like possibly an underlap, if not just totally lined up, which you would think would move the transverse process on the left away from the styloid process on the left. But I found that that also depends a lot on how the joints are shaped. So if if we're moving backwards along a joint that's curved, tilted up enough, you're actually going to be moving that side, this transverse process, closer to the spinous process because you're rotating backwards. Now, the bone itself isn't rotating in relation to the other bone. It's moving within its normal range of motion on the right side, and it's come out of its normal juxtaposition on the left side. But as it rotates, it looks like we could possibly have a change here, but it was such a small misalignment that probably not. So this might be normal, completely normal for this person. It'd be interesting to get an MRI if we felt like after adjusting them and all the neurology cleared, are we still seeing symptoms that are related, might be related to cranial nerve 10 on the left and uh, the jugular vein and or the artery there. So anyway, that is pretty much the complete Blair analysis. I tend to do a lot more. I look at a lot of different things. Some of the procedures I personally change a little bit to make a little bit more sense with what we're doing now, but we haven't done the official studies to change anything yet. So that I don't think I've missed anything. Now we would have to decide how we were going to adjust that C1 PIR. Are we gonna come back on the right side and push it forward to the left? Are we gonna come over on the left side and use a different um, angle, a different leverage point to push it backwards, as well as helping to bring it back towards the left? We have a couple of options with that. Uh, and I will figure that out tomorrow when the patient comes in. Okay. Any questions, comments, concerns? Okay, this will be this has been recorded, and you'll get an email. And anybody who has signed up to be here but couldn't make it will also get an email, and you can download it. Feel free to share it if you want. I'm not copywriting anything. It doesn't take the place of a certification, seminar, anything like that. It's just hey, here's how we do it in the Blair technique, the simple yet effective way that we teach it in the manual. And we go from there. Y'all have a good day, and I hope this was of some use.